and apply overpressure through here, and further up and apply overpressure through there. So to look at side flexion, I'm first of all going to look at side flexion to this side. So I'm going to, again, guide him down. So you're going to bring this ear down to the bed. And again, here I'm looking at that thoracic curve. And again, we can see it doesn't really change that much. It stays quite straight, particularly here. Moves a little bit more here, but stays quite straight here. And again, bring him back up. And again, back down again. And this time I'm going to apply overpressure. So again, I'm applying overpressure through this hand here. Okay, to look at side flexion to the right, I'm just going to get him a little bit closer to the edge of the bed. So just want you to bring your bottom over here. Okay, this is more for the therapist posture, to make sure that I'm in a good position for applying pressure in the other direction. And again, I'm going to get you to bring this shoulder down to the bed. And again, I'm going to apply that overpressure. And again, assessing side to side. We can also look at rotation. So again, I'm going to ask you to turn your upper body to me. And again, looking for the range and back again. And again, to me. And this time, applying overpressure and getting that end feel and symptom response. And then repeating it to the right. And again, over and applying overpressure. Again, looking for that. And you can see with all the movements that this is quite a stiff region. This is quite common. It is a naturally stiff region. So you must try to establish, is it stiffer than normal or than you would expect for the person's age? And remember, the thoracic spine does get stiffer, naturally stiffer with age. And it'll also tend to get a little bit more kyphotic with age. So that must be borne into account as well when assessing. We can also look a bit more thoroughly at the upper thoracic spine. And again, the upper thoracic spine really tends to move with the cervical spine, so it does tend to contribute to cervical spine movement. So we can look at the cervical movements as part of the upper thoracic spine assessment, but we could also look at things such as arm movements, particularly with extension. So for example, I'm going to get you to bring your two arms down by your side. So as we elevate our arms, our thoracic spine has to extend to allow for that elevation. So I'm going to ask you to bring your two arms straight up in the air. And again, you can observe what happens through here if he tends to extend through that thoracic spine. And back down again. We could do it with one arm for unilateral movements. I'm going to get you to bring this arm up. And again, assessing that movement through there. Sometimes it may not be that obvious to see it, and you might find cervical movements are more relevant for you. But particularly if somebody is quite kyphotic through that upper thoracic spine, and if they have a shoulder problem which is being influenced by a thoracic spine problem, then it might be appropriate to look at the shoulder movements as part of that assessment. We can also look at combined movements in the thoracic spine. So again, I'm going to get you to put your two arms across your chest. Again, we can do closing or opening movements or regular or irregular patterns. So we can do, first of all, a regular pattern of closing, which would be extension, side flexion, and rotation to the left will be closing on the left. So we can apply extension, side flexion, and rotation. And again, this is going to close down that left side. Again, assessing that symptom response compared to the general movements. We can also do a regular opening pattern. So for example, if we wanted to look at opening on this side, we would do flexion and side flexion to the right and rotation to the right. So again, I'm going to just get you to flex down, bend in through here, through the mid-back. And again, we're going to side flex and rotate. And this is now effectively opening this side. We can also do repeated movements, as I discussed, in the cervical spine. To test compression through the thoracic spine, I can get Dave to put his hands across his shoulders again. And again, I can just apply a vertical pressure, loading through there. And again, really this is a symptom response test rather than looking at movement or quality of movement. And again, thoracic spine is quite hard to do distraction, depending on the size of your patient. It might be quite hard to apply that pressure, but you would come in from here, come in nice and close, again, at around the level you want to affect. And again, you're going to lift up like so, assessing the difference in symptom response between compression and distraction. We can assess rib mobility by looking at the patient's respiratory pattern. And again, this is important to have the patient appropriately dressed for this. Okay, Roshan, I'm just going to ask you to take your top off. So it's important to remember that in normal relaxed breathing, inspiration is an active process whilst expiration is passive. Expiration becomes more active during activity. We have two types of movement that occur in the ribs during the respiratory cycle. Between ribs 2 to 7, the ribs move in a pump handle action, which tends to increase the AP diameter of the chest. The movement at ribs 8 to 10 is a bucket handle action, which increases the lateral diameter. Ribs 11 to 12 remain fixed during inspiration and expiration. The joints which move during this respiratory cycle are the sternocostal joints, the costovertebral joints, and the costotransverse joints. It may be particularly relevant to assess the patient who attends you with a respiratory problem but has associated musculoskeletal symptoms associated with that. So in normal relaxed breathing, inspiration is an active process while expiration is passive. However, expiration may be active during activity or during a cough. In assessing rib movement, we must appreciate the types of movement that occur in the thoracic cavity. So, for example, between ribs 2 to 7, there is a movement called the pump handle action, and this increases the AP diameter of the thoracic cavity. Between ribs 8 to 10, there is a movement which we call the bucket handle action, which increases the movement in a lateral direction. Ribs 11 and 12 remain fixed during inspiration and expiration. The joints which move during the respiratory cycle include the sternocostal joints, the costovertebral joints, and the costotransverse joints. It may be particularly appropriate to assess the patient who may have an associated lung disorder, and they may have associated musculoskeletal symptoms with that. When you're assessing the breathing pattern, try to assess informally initially, as formal assessment may affect the patient's normal breathing pattern and it may change due to the fact of being observed by the therapist may increase their anxiety. So again, you would just observe them as part of the informal assessment, again watching for the, where the dominant breathing pattern occurs, whether it is apical, diaphragmatic or lower lateral costal. To then assess more specifically, you can palpate with your hands at the different levels. And you're going to compare side to side and level to level. So for ribs 2 to 7, I'm just going to ask you just to breathe normally, just your normal breathing pattern. And I'm going to just palpate here. All I'm doing is just feeling how the ribs are moving during that, okay? So again, just breathing in and out in your own pace. So again, for ribs 2 to 7, you would assess anteriorly, just to feel if you can feel asymmetry from side to side, and also as you move down. In the female patient, obviously, you will be limited in this area, but then you can assess further at the posterior aspect. You can assess ribs 8 to 10 here. So again, you can keep your arms nice and relaxed, but just a little out to the side like so. And again, you can palpate the lateral expansion. To assess posteriorly, I'm going to ask Roisin just to move position. So nice and slowly, I want you to turn around just to face the wall. And again, arms nice and relaxed down by the side. And again, I'm going to go back up. And again, assess the AP diameter changing here. And again, once we get to this region, again, we're looking more at the lateral expansion.